we have Melanie Almonte, who's an ICU nurse and researcher and epidemiologist. We have Tony Bonill, who is a doctor. We have Ana Baltasar Corral, who's also a doctor. And we have Richard Barron, who's also a doctor. And so I will not go on a long introduction of all of you. Maybe you can do that while you answer my first question, which is for the panelists, which is, could you tell us more about where you're calling from, what your job was before the pandemic, and whether it has changed because of the pandemic? And so just like a bit about your background in the healthcare sphere. And perhaps we can start with, let's see, with Ana, and then Richard, and then Melanie, and then Tony. How's that?
Fine for me. Well, I'm Ana Baltasar. I was a camper in 2008 and 2010 as a second year. I'm a neurology resident here in Madrid. I come from Spain. And my job is to learn neurology and also to work in those wards. I was on my rotation ward in the neurology ward on March. And as you may know, the emergency state was declared in Spain on the 14th of March. So we were asked if we were able to relocate to the COVID wards. And I did so. And I've been working on those wards till May, where when the situation winded down and we're back to our normal rotations. And that was my job before, and it has changed a little bit. And we will go further into that in the next question, maybe. And yeah, that's pretty much, I'm Spanish and I've been living here for the past years. So I don't really know that much about the healthcare system in other parts. And I hope that also is brought to the conversation, since I think it's different how we deal with some problems.
I'm Richard Barron. I was at camp in 67, 68. I see Carl Schoenberger and Mike Blaber on the call, in addition to Richard Jones. So we're well represented from that cohort. I took my life-saving training and was a New York City lifeguard. That was my college job, Richard. So you launched a career. I basically had a 30-year career of community practice, primary care, internal medicine, and geriatrics in the community in which I lived. I had a side career involving Medicaid managed care, and actually left practice to lead a group that at the Innovation Center at CMS, changing payment for primary care and ACOs. But then was recruited to become CEO of the American Board of Internal Medicine, which is what I do now. When you hear the expression board certified doctor, we're the board that certifies 1 in 4 doctors in the US, because internal medicine is the largest of all the disciplines. In terms of my day job, I haven't been that much, frankly, neither I nor my organization has had different impact from COVID than any number of other organizations. We had to start working remotely 3 months ago. We canceled all our meetings. We convene usually national meetings of doctors who are experts in their fields. And the idea of bringing doctors together during the pandemic is a bad idea. So we didn't do it, and we're not going to do it for the rest of the year. We are pretty connected to the training environment that Ana's talking about. And from our point of view, one of the kinds of things we worry about is people who are trying to train in a particular area need a certain amount of time to train in that area. And what's happened during the pandemic is, first of all, they've been pulled into service in other areas, as Ana describes. And second of all, depending on their area, in the US, people stop going to hospitals and routine procedures have basically just been suspended, closed down. And that's had major consequences, both in the training space, because people aren't having the opportunity to learn the things that they need to learn. And it also has had huge financial and economic impacts on the entire healthcare delivery system, where there have been lots of layoffs and furloughs because their revenue in our country comes from largely elective high-margin procedures like total hip replacements, total knee replacements, which are just not happening. So it's such a privilege to reconnect with CRS people, and camp was so important in my own personal development. It's just a privilege to be back with each of you. And thanks, Eliam, for the invitation to do it.
Thank you. Melanie, would you like to go next?
Sorry, I had to figure out how I unmute. Can you hear me, or is the Wi-Fi still a bit fiddly? Okay, good. So I'm Melanie Almonte. I went to camp in 97, 98. I was a counselor in 04, a volunteer throughout several of the years, so visited Stendis when it was open, and I was a counselor in 2013 as well. I was a nurse there. So I am a nurse by background. And I worked in New York City. So I came from South Carolina originally. I moved to New York City and then moved to London to do grad school. I went to London School of Hygiene and Tropical Medicine. So for any of the UK people or European people, Prof. Chris Whitty was a professor at my school. He's great. He's lovely. He's very approachable. And that's where I was supposed to go do my PhD, and then COVID hit. And I was getting the funding sorted out. But then all this happened, and I had the option to just stay at home and just write up some studies. I was designing a few trials that we were doing in my group, but I didn't feel right that I stay at home, and we have such a dearth of critical care staff here and nurses. So I came. So I'm here in London, where I live now. I'm still working on the floor. So many of us were redeployed. So all research pretty much was put on hold completely. So it's not like I could do anything anyways. So I came. I've been working as a nurse in critical care here for the past 3 months now. I haven't been living at home. So I moved out because my housemate, she's my parents' age, and she has like the complete clinical picture of many of my patients. And at first I was going to stay at home, and she was fine with it as well. But then after just seeing more and more patients come in that looked just like her, with hypertension, high cholesterol, pre-diabetes, young, old, it didn't matter. They were coming in. And so I decided to move out. So I've been living in hotels. I'm still living in a hotel. And I'm hoping to go back maybe July, August back home. Not really sure. Yeah, so my day job, though, is as an epidemiologist. So I design studies, I write up studies, and I'm doing my own fellowship in ophthalmology, where I was bringing children, well, they're adults now, but they were blinded in childhood, actually blinded as infants, back into London to do a whole series of exams. But you kind of can't do that right now just because public transportation isn't at its very well. And also these are very vulnerable people. So yeah, that's where I'm at. So I'm at hospital. Sorry, I'm at work right now. And I'll have to run like right on the dot. So, cool. And thanks, Eliam, so much for setting this up also.
Thank you. Tony, would you like to tell us a bit? Yeah, thank you.
Sure. So I'm a private practice allergist, immunologist, living and working near Boston, Massachusetts, the state with the second largest number of coronavirus cases in the United States. I'm in private practice now, although I was in academic medical center for decades prior, working mostly on immune deficiency and treatments for those diseases. Our group elected to remain open, unlike many subspecialty practices in our area. We wanted to stay open to serve our patients, even though the volume of patients that we were seeing reduced by more than 50% over the course of the slowdown and all the social distancing restrictions that were put in place in Massachusetts, which are only in the last week or two beginning to be slowly lifted. Patient volume is picking up a little bit, but still very far from pre-pandemic levels, as is the case pretty much across the board for outpatient medicine throughout the world. We are not certainly at the front lines of treating coronavirus. In fact, we work very hard to try to keep the virus outside of the environment of our practice, but we're operating under extremely strict guidelines from the Department of Health about how we go about doing these things, and procedures and so on that were previously routine are now considered high risk and very restricted. So it has definitely changed very much the nature of how we are practicing currently.
Amazing. Thank you all for telling us a bit more about yourselves and about your healthcare experience. So I have one pressing question before I let other people ask questions. And so basically, as you likely know, Black communities in the US and BAME, or Black and ethnic minority communities in the UK, have been disproportionately impacted by COVID-19, both as far as I understand in infections and in deaths. And so I'm wondering whether you can speak to what that reveals about our healthcare systems, and perhaps what that reveals as well about the inequality in our social systems more generally. Would anyone like to take this question first?
I'm happy to take a shot at it, and to own some responsibility. The way we teach medicine, and the way we think about medicine, we think of it as a science that's about the viruses and the way that they infect people, and what are the mechanisms of infection, and what are the modes of transmission, and we think about treatments. And we have what has been an incredibly successful paradigm to eradicate various kinds of diseases, and a lot of, we tell ourselves a story of great progress in the 21st century. But if there's anything that we've learned from COVID, it's that that's a really impoverished understanding of how to think about medicine and healthcare, because all of the ways in which the virus has spread through the community have to do with housing, have to do with employment, have to do with travel, have to do with all sorts of things that we don't think of classically as being healthcare. And if what healthcare is about is supposed to be keeping people healthy, COVID has shown the way in which the disparities, which have been recognized in the US for 20 years. I mean, the Institute of Medicine published a study called Unequal Treatment, demonstrating structural racism in American healthcare. And people talked about it, people thought about it, but COVID's been pretty stunning. And all of the combination of data science being able to show this stuff in real time, it reveals something about disease that we didn't used to be able to see, almost the way that MRIs reveal stuff we didn't used to be able to see. And I think it's going to change the way we think about what healthcare looks like.
Thank you, Richard. Ana, would you like to speak to this as well?
Yeah, I pretty much agree with what he said. And it's also very interesting to see how we tend to forget about the social part of medicine. And it's a very important part. Like, disease deals with this, and we've seen here, specifically, I can talk from my hospital. I work in a very big hospital in Madrid, and you can see how the patients spread the disease on their houses and their workplace. And it's very interesting to see how this was more prominent in Hispanic people, because here they usually live in tightly knit communities, and they live in smaller houses. And it's also quite interesting to see how the carers of old people have been one of the main vectors. We've seen that as well. And it's usually low-income people that work for high-income people. And some of them were hard hit, and I think we tend to forget that the social part it's very important, and we don't deal with that on our daily practice, and we should be incorporating that into our questions and seeing if we have a public health system here, but it's still, we don't have that many social support for the people that are in need. And we may be, we may think about changing that in the future so that we can prevent more of these things from happening. And I would consider that to be one of the most key things to change in the future, how we deal with the social inequalities in health. And it's been known for a long time. So we know this happens, but we just don't do anything about it. So I think we have to change that, or try to, at least.
Thank you, Ana. Tony, go ahead.
Sure. Along the lines of the previous comments, there's two issues. One, has to do with elder care. Most of you are probably aware that a tremendous disproportion of morbidity and mortality with coronavirus in the U.S. Is among the elderly, and this has a couple of reasons. That I think institutionalized elder care is more prevalent in the U.S. than in many other countries around the world, and at the same time, the resources that are given to institutionalized elder care in this country are extremely limited, and many people who are in those care environments suffer from the lack of resources of the staff. They're understaffed. The staff have poor equipment and poor training as far as disease prevention and things of that nature are concerned, and that has become abundantly clear over the course of the pandemic, and is one big social issue that remains to be addressed. And then the other, as has been also alluded to, has to do with the fact that social distancing is predicated upon a certain economic situation, and most of the lower income jobs in the service industry that are held predominantly by people of color, and in those circumstances they simply do not have the option to practice social distancing because they cannot work from home, they can't maintain their employment, they can't maintain their livelihood. And so this is another vulnerability that has clearly been brought out by the pandemic.
Mm-hmm.
One thing, Ellie, I might put a little historical perspective on it, that we just all accept the germ theory as if, like, it's uncontested. It's like, there it is. It was proven by Robert Koch in 1880. There's a wonderful history of medicine piece about arguments about the germ theory in the 1820s, before allegedly they had definite scientific evidence to prove. And there were two different competing schools of how disease was caused. Some believed it was germs, and others believed it was miasmas and environments, which we think of as a discredited theory. But what the historian points out is what united the scientists was actually their politics, that the people who believed in the germ theory believed in the separation of rich and poor, believed that you didn't need to worry about housing and sanitation. The people who believed in miasmas said you need to focus on structural conditions in communities because that's where diseases come from. And it's interesting that we think of miasmas as a discredited theory, when in fact it's sort of the parent of current social determinants of health. And a wonderful book, if anybody wants to look up a Marxist critique of American medical science, it's called Rockefeller Medicine Men, by a guy named E. Richard Brown. And he argues that what was happening at the Rockefeller Institute in the early part of the 20th century, as they were building the foundational science that led to so many medical breakthroughs in the 20th century, he says it was basically Rockefeller funding a school of research that would say it's not our fault that we, the capitalists, operate all of this. It's not our fault. It's these germs. It's these viruses. It's this bacteria. It's not us. And it's really interesting that, I mean, of course, it is germs and viruses and bacteria. We know that, and God willing, people will create effective vaccines and effective treatments using that science. But recognizing how deep this goes is important, that you can't just add social determinants of health as sort of a frill to medical education. You need to think more broadly about illness in the community.
Thank you for adding that, Richard. I'm wondering, Melanie, would you like to add anything to this? Or
gosh, I feel like everyone's kind of said everything before I could take it out. One interesting thing, because the UK, and I'm assuming it's kind of like Spain, where we have like the social healthcare system, it's public health, everyone has access to it. So I think the first thing, I'm wondering if people thought, because when you look at the research, I don't know if there's any studies yet in the US that has really looked into it, because here, Public Health England has had to write a report, and there's so much money now and so many people looking at to see why certain communities are hit more than others. It's actually a new stance for my PhD. So I'm waiting for my supervisor to get back to me to see, because I was looking at particularly at healthcare workers. And at least for us, it really is the key workers, the people that you also didn't think were key, like the porters, the bus drivers, who are predominantly BAME, who are actually more affected. And at least in this country, when it came to the lockdown, these were the people who were still able to work. So even your construction workers, they were considered key workers, and we're finding that they're the ones. So it's all of us. So it's interesting, because if you put these all in models, it's very difficult to disaggregate them to say, is it really because of color or because of the role of the job that they work in? Mm-hmm. And then what really drives them to work these jobs. I mean, that's a whole nother history to look at. But there's also a thing that, like, for South Asians, so people from India and Pakistan descent, and Bangladesh, I just guess many studies shown it's not genetic, but for some reason we see heart disease and diabetes at lower body weights. So that's, I mean, I like I said, I don't really go into the science more of it, just the stats to say that. But we're wondering, like, if you can take that away, is it diet, is it exercise? So, I mean, there's so many threads. So it's not just like the social aspect of it, but that's one. And I think the last thing that I don't know how much research is yet, so what I'm looking into is environment. So at least here in the UK, we're showing that a lot of BAME communities do live near trash incinerator sites or have like higher particulate matter in the environment. And we're thinking that could also be another thread. But it's interesting when Richard, we were speaking about the whole idea about miasma and just really caring about the environment that you're in and clearing things out. And it's funny because it just seems like it's coming back a little bit full circle in that way. And it would just be, interesting to see how that kind of works out, because that we're finding, especially here in London. So I live in Hackney. And if you look at the places I'm not sure if it's just London or all over the UK, the worst hit are Brent, which is right above me, another area that's close by in Hackney. And not only do we have a lot of BAME communities, but we have really high particulate matter. So yeah, I think that's the only thing I wanted to add.
Thank you. Thanks all for answering my question. I think Carl had a hand raised, and also from now on, please feel free to raise your hands, and I will I'll give you the word.
No, I just wanted to make the point. I think it's already been alluded to that one of the probably unique characteristics of the U.S. is that we do not have universal health care, and that's often cited as one of the important factors looking at the overall health indicators here, which of course are much worse than every place else in the OECD in the advanced economic countries. But as has been just pointed out, there are these multiple other issues which even in those countries like European countries that have universal access to care, that is not in and of itself enough to compensate for all of the other disparities which exist. So that's another thing to keep in mind, that universal health insurance is obviously, or access would be very key, but that's not the end of the story.
Right, and Carl, if I could, I was on a call yesterday, it was really interesting. So not only do we not have universal health insurance, but we have an employer-based health insurance system, and over 30 million people in the United States just lost their jobs. Which means they've lost their health insurance. It seems like many of them may have been furloughed and their employers may have continued to cover them rather than laid off, because it doesn't seem like there's been a huge spike in the uninsured. But if there is, it'll turn out that the Affordable Care Act will be, in effect, a safety net for uninsured people that we never had before. And some of those people will qualify for Medicaid and will get care that way. Some of them will wind up on the exchanges. It's fairly complex to navigate it, and the current administration has slashed the education budget for outreach and navigators and all the infrastructure to help people sign up for this stuff, they've slashed the budget 90%, and they're not doing anything to make people aware of a social safety net that exists, which is just shocking.
Yeah. Thank you for commenting on that, Richard. Would Anna, Melanie, Tony have anything to say on the different kinds of healthcare systems?
I'll only echo the comment that nationalized healthcare, I think, would solve a tremendous number of problems in this country, and it has to be at least one option, if not the only option. I think that at least is debatable, but as has been alluded to by many, nationalized healthcare in the U.S.
I guess I just want to add also that even though the NHS is a national health service, it's been privatized over the past decade by the current government. So even if you go, say, for instance, to one hospital or one GP, if you move somewhere else, you have to bring your records over. There are, just in London itself, about 31 at least different medical record systems. So even transfer of care. I mean, you do get stuff for free, but it's just like if you move to different towns in the US where you have to register, you have to go through all this paperwork just to get it sometimes. That, and also there's something we call a postcode lottery. So say, for instance, you have a mental illness, you go to your GP, it'll take the GP maybe about a year of giving you like several different types of antidepressants, trying to figure it out, like what you need. This is just a really crude example. Then they give you over to a psychiatrist on the queue, and you're in a queue for maybe about a year or 2 years before you get anything. But that's if you live in, like, say, Camden County, in Camden, in London. But if you live somewhere with a bit more affluent, like Chelsea and West Mid, you'll be seen a lot more quickly. So I think, at least when it comes to disparity, we do have it here in the UK a great deal. And I think one of the things, and I'm a big fan of the NHS, so I moved here, one of the big reasons is just funding it. So it's interesting because as much as you'll see, like, we really do love our NHS, it's not really up to the people, and because we'll give all our taxes if we could. I mean, I pay about 40% right now. And I gladly do it. But it's interesting, I guess, whoever does like the policy side of that, I think that's, at least from my little grunt point of view, even though you do have it free, I think it's just where the money is allocated. It really depends on who gets access to it. So.
Yeah, it's pretty much the same in Spain. Like, we have a public health system, but then you have different resources in the different places that you live. For example, in Madrid, you have very big hospitals, you have a lot of specialists, and then if you go to where I come from in Cáceres, we don't have that many resources. And I think one of the main problems with this pandemic, it's been that the healthcare system became, it was overwhelmed. That was one of the main problems that we had here. Like, my hospital has like 1900 beds. It's like a huge hospital. And it was all COVID. Like, we didn't have, we had our stroke units. We have all the ICU units were full to the brim. We have 40 beds, and it became 150 beds. Like, it has been a constant influx of people, and we did not have the resources because progressively on the past years, the governments have taken away a lot of money from the public health system and relocated that money to other sort of systems, not only private health, but maybe other things, not necessarily healthcare. And healthcare is one of the main pillars of our society, and I think that we should do something about that in the nearby future, because this is going to continue to happen. We need to be prepared for that, and we're not. We didn't have, for example, at the beginning, and I think this brings up another topic, we didn't have the protective gear. We asked for it and we didn't have it. I remember seeing patients in early March, and as I said, I'm a neurologist, so I'm not in the emergency room all the time. And when we wanted to see a patient, we needed to tell our supervisor if it was suspected that he had any contact with COVID patients, because if he had not had that contact, we will not be given the protective gear. And some people were asymptomatic and they were transmitting the disease. And that's one of the things that I also wanted to bring up, how the healthcare workers, we've been underprotected, and we've been very hard hit here in Spain. Like at least 60,000 healthcare workers have been infected, and at least 100 or so have died because of this. And we know that we are in a risk position, and we assume that when we start working in medicine or as a nurse or as the other positions in healthcare. But it's very important that we are given the necessary resources to work and to provide for our patients. So yeah.
Thank you, Ana. Would anyone have any questions? I don't see any hands raised. I have more questions to ask, but I'm mindful of time. So if people do have questions, please don't be shy.
Okay. Can I ask a question of Ana and the, one of the things we talk about in the U.S. and I guess for Ana and Melanie, that we disproportionately fund the acute healthcare system, the hospitals, all that stuff, and we don't fund the social service system as much. And we hear that in the EU, the social service system is much more generously funded than here. Okay. I guess I was going to ask the question, of the services you have, which have been the ones that have been most helpful? I mean, I understand you could always use more, but as you sit in acute hospitals and you think about what's out there to help you do what you're doing when people leave, what are the things that you think have made the most impact in your systems, in your societies?
I think GPs have been a very important part here to control the coming to the hospitals in mass, because as I said, the hospitals have been full to the brim, and the GPs have been helping us to care for the not so severe patients. They've been calling them, they've been visiting them at home, and that has been a relief for the hospitals. And also I believe that even if we have a little bit more of social services, it's one of the things that has been very underpaid, as to say, and we've had the problem with institutionalized patients, as Francisco said, that we couldn't send the patients that needed an institution back to the institutions because they were positive and they were a risk of infection for the other patients there. And also we've had a problem with the rehabilitation centers for young people that as a result of prolonged stays on the ICU wards have had some complications and they need rehabilitation. For example, the critic polyneuropathy. That's a very important thing that we've seen because the stays in the ICU have been long. They've been like 3 weeks at least. And I think we need to work on those things. Also, a good program that has come in the Madrid healthcare system has been geriatrics specialty. They've been going to the different elderly care centers, and they've been supervising how they were working, the resources that they had, and they've given some resources where they could. And I think that's a thing that should be implemented in the future, because as we said, maybe the workers there don't have the resources and they don't necessarily know how to deal with these patients. And if you have someone that can teach them, and maybe we can prevent further spreads in those communities from happening. And I don't think if Melanie has a different opinion, because I don't know how this whole social systems work in the UK.
In the UK, it's a bit different because the way you describe it sounds like a dream. So the people do really depend on GPs here. I think GPs are the largest body. It's a very popular job too, by the way, here.
Here is not.
Oh yeah, exactly. And in the States, I remember my friends that are residents are like, yeah, no one wants to be a GP. But here, everyone does. They're like, yeah, I would love that job. It's 9 to 5. It's funny to hear that. But we also have quite a shortage of GPs as well. I mean, I think before the COVID outbreak, you would have about 3 weeks at least just to see your GP. I mean, it was miserable. So many people, and I don't know like politically how that worked out. I think it had to do with defunding as well. So many people were just using A&Es instead, our emergency rooms. Mm-hmm. And then I remember there's a push to move them back into GPs. And anyways, it was a bit of a mess even before. And then during the outbreak, I think GPs could have been a massive help. But what the government told patients was to not go to your GP. They said to call, I think it's 111 is the number here. Don't call 999, which is like 911, call 111. And they'll direct you where to go. Do you go to a hospital? We'll send an ambulance to you, or we'll tell you what to do. And I think that was one massive issue that they did. GP offices were pretty much closed. To even call one was a disaster, because I had to call mine because I had some appointments, and they were really unsure whether or not they would go through with some appointments versus others. And then I think they were closed completely for a while, and were only seeing people that they really needed to see. But I think GPs could be amazing if anything, if the government or whoever organizes their care can do a really good job of it. Because we had a lot of people just end up going to A&E or taking an Uber over to A&E or dying in their homes. I think that was one thing that we're just finding out now also. But definitely, if we have, I feel like the people here in this country, and Arya or anyone else can probably tell me differently, but I feel like we really believe in preventative care. And I feel like people are very local here. So when you have your GP, it's like your little area. And it's like your little community. So you will go to it. But not just, unfortunately, not during this outbreak, but they are opening up more, but still only seeing very few patients. And I don't know, I haven't seen anything of when they'll be opening up, but it has been, I remember seeing a trend towards people really just using emergency services because it took so long to get GP appointments. And they would try to use A&Es and the specialists that were available there. But then at that point, hospitals stopped referring them to specialists in the A&Es. They would treat them immediately for whatever you needed there if they could, or tell you to go back to your GP. Mm-hmm. So I think if you have a better marriage between these systems, then yeah, it would be great.
Melanie, Ana, telemedicine really took off in the U.S. Like we've been talking about it for years. I don't know, talking about your experience of, you said your office stayed open. I don't know if you started offering telemedicine visits, but in the U.S., primary care shifted pretty much 100% to telemedicine.
Yeah, we were doing telemedicine probably 50% of our encounters at least during the height of the pandemic. It's begun to quiet down a little bit, but there is still a tremendous amount of telehealth. But that wouldn't have happened if there hadn't been an order from the governor that health insurance companies would be required to reimburse telehealth at the same rate for an in-person visit during the course of the pandemic. That order hasn't been lifted yet, and it probably will at some point, at which case they'll go back to their posture of actually not reimbursing for telehealth at all. So that was the one thing that really facilitated the explosion of telehealth here. I don't know in other states, what the insurance issues have been, but historically, at least in Massachusetts, telehealth has not been reimbursed, and that's been a big obstacle.
Thank you. We have 4 hands and 14 minutes, so I'm just going to take all of them at once so that to see whether we have similar questions. So maybe, and if you could please keep the questions brief, that'd be awesome. So first Rihanna, and then Dick, and then I'll put in on you.
All right. Hello, everyone. My name is Rihanna. I went to camp in 2008 and 2009, and I worked there in 2012 and 2016. I currently work in Yemen for a humanitarian organization. I'm not in Yemen right now because of the international travel restrictions, but you were talking about the systems and how different systems have dealt with it. In Yemen, only half of the healthcare system was working before COVID-19 broke out in Yemen because of the war that's been going on for more than 5 years now. I have a lot of staff there. Some of them have been sick already with COVID-like symptoms, but there's basically no testing. There is a completely crippled healthcare system, which is already half working. And I was just wondering, from your professional experience, how can I support my staff that are still going out to the communities, because we do life-saving support in terms of both health as well, but mainly access to water, access to cash. What can I do to support my staff to work in the midst of Corona when you basically have no healthcare system to deal with it?
Thank you, Mariana. Dick, would you like to ask a brief question? Thank you. I think you're muted.
Yeah, no sound.
Sorry. Two brief questions which are on the minds of most people. A, what do the medical folks, can you give us an update about the relative availability of testing in your areas? And B, can you give us an update that's truthful, basically, so I can get past all the social media chatter about the prognosis for developing therapeutic drugs and a vaccine?
Thank you, Dick. Johan? Also, hey, Johan. We can't hear you.
Can you hear me now?
Yes.
No.
Okay, good. Because I was just wondering, I'm from Sweden, and as you may know, we have a whole different tactic about the coronavirus. So I was just wondering, do you think that Sweden has done the right thing in the long run? Because the government here, they say, oh, we don't know yet if we've done the right thing or the wrong thing, because we have to see that in the long run. But do you think that Sweden made the right call to not make a lockdown?
Thank you. Vera?
Yep. Hi. Yeah, my question is, we've been talking a lot about fundings, and I'm still a little bit unclear. So I would love for healthcare workers in different countries or regions to recap on whether there is enough funding right now in your respective regions, and who are paying for them, and is that a good mechanism in your views?
Thank you, Vera. Anthony? Anthony DeFranco, are you with us? Okay. Well, if you come back later, let us know. Okay. So
hi, how are you? I'm back.
Amazing. Thank you.
I'd rather suspend my question, and maybe I can help to give some of the answers with respect to the gentleman who asked about vaccines. This is an area of interest of mine. We're working with 4 different companies to try to clinically test vaccines. It's unknown. It's very difficult to develop vaccines to human coronaviruses, and in particular because this strain seems to have mutated into at least 12 different strains already, and many of the mutations have been along the spike protein. So whether or not we can develop a vaccine that actually conveys immunity as opposed to merely IgG antibodies remains to be seen. To my colleague in Spain who was lamenting the lack of PPE, this is a universal phenomenon. While my not-for-profit, for-profit health system, which made more than $7 billion in revenue last year and whose CEO retired with $65 million in final year pay, we still have our PPE locked up. I cannot get access to N95 masks, either for me or for my high-risk patients. So it's not only in Europe and other countries, it also happens in the US. On the other hand, we also offer free testing by both PCR and antibody testing right now. So it is rather diverse. Finally, a question for Dr. Barron. Dr. Barron, do you agree that it was really a black eye on both the Lancet and the New England Journal of Medicine to so quickly rush to publications data that was questionable on hydroxychloroquine. Not that I'm an advocate of the drug, but how could those two leading journals publish those very important articles without a thorough review of the original data?
Awesome. Thank you.
Oh boy.
Thank you, Anthony, for both answering and asking a question. Perhaps, Richard, would you like to take that last one? And then if you could each take one, that'd be awesome. Thank you.
Sure. Very quickly, I think we're living in a world where everything's moving faster and everybody's trying to get information out. And I think what they're hoping is to put information out and let readers in the community decode it. And, as you know, there are now a bunch of online archives of people just posting their raw hospital data that people in the field are trying to process. It makes you wonder what the function of journals is. But it's never a good day when a journal publishes something that hasn't been reviewed, for sure. And if I could very quickly for Ariane, because I think you asked an urgent question, you're not going to have PPE, you're not going to have testing, you're not going to have treatment. So you're really going to have to rely on social distancing and hygiene, and you're going to have to try to give people everything you can in terms of hand sanitizer and soap and water and whatever it is, and masks, and tell them to try to maintain distance and use hand sanitizer, because you really don't have a lot of resources.
Thank you. So from the other questions about Sweden funding, would anyone else like to answer them? Thank you.
Oh, sorry, I have to go in 5 minutes. If that's okay.
Go ahead,
I don't really know what I can say about Sweden. I haven't really looked at the numbers. I just know that they have really high deaths, but I feel like everyone kind of knows that. That's per 1,000 people. So I will skip the comment on that until I read a bit more. But Geriana, I was thinking for you, so I teach on the Diploma in Tropical Nursing course here at London School. And I remember it's one of the things that we always think about, like, what can we do when we have nothing? And one of the things that I think every person that's given this lecture, they've always said just water. It doesn't matter how cold, dirty, clean, because honestly, as long as you have some soap, soap is hydrophobic and hydrophilic, so whatever it touches, it'll take on, and then when you wash it, it'll wash it off. Doesn't matter if it's warm, cold, if you can boil it, great. Don't touch your face. But yeah, I think what you said earlier, just social distancing, if you can do that. Or even what we found is just like any standard mask, 2-3 filters, doesn't have to be fancy, just a shirt. Just something. But also a lot of it, if you think about it, is very psychological. So to also make them feel comfortable about it. I don't want it to be a complete lie or a placebo, but I think if you're not anxious and you're in a very, really tough situation, the less you have to worry about, the better. Just seeing like so many type situations. But I do want to say something about when it comes to treatments. So for us, we found, we have several studies going on right now to see like, when you give someone steroids, like how long will it take and how well will they do, and antibiotics, like off and on. But what we found regardless is time, really. So right now we have 4 patients, and about a month and a half ago we had about 68. So we were in ICU, just one floor. We stacked out to 3 different floors completely, and the whole hospital was about 95% COVID. But we had a really high, I don't want to say too loud, we had a very high death rate. So if you were intubated, I think the first month and a half, we had not successfully extubated someone, meaning they had not successfully been taken off the tube. They passed. So whenever we have a patient, I feel like that was the last thing we wanted to give them. So we tried hard. We gave them CPAP, non-invasive, anything else, until, of course, that was the last resort. But now what we're finding, and many of them, of course, died because, we had to extubate them. And now then finding out is, we didn't have enough vents. That was one thing. And then when we did, we had like really rubbish vents that you can't wean off of. But the next thing that we really ran out of, that I think was a big game changer for us, were filter machines, dialysis. So a lot of people needed dialysis because they're developing all these blood clots. And we're thinking many of them like stroked out or developed had TIAs or transient ischemic attacks. but filter machines. So we ran out, and any patient that we had to take off prematurely passed. And we had to do that several times. We had to make, not us thankfully, but it was a multidisciplinary team decision on who would get these machines. Mm-hmm. So, but what we're finding now is that we have 4 people left, and there was about 7 last week and 8 the week before. They're all living. It's because we're thinking they've been with us for so long. And these were people that we thought after the first 3-4 weeks, it was done. Just, we should talk to the family about that. And they did. But all of a sudden, like, they've all just started picking up. And just like now, I mean, we're giving them oxygen and it's actually responding. So we're so surprised. But it honestly, it just takes a lot of time. And I feel like, and for us with the NHS, because we're so overstretched, we unfortunately we couldn't give all these people that luxury. And I worry that places like in the US, where it's very money driven to a degree, I'm probably wrong. I haven't worked in the US in like years, in like 6 years, but where I worked in New York City, it did feel like that time crunch and that money crunch. But here, yeah, I just want to say, I think it just takes a lot of time and patience. And if we have that, so that idea of flattening the curve so we don't overburden our healthcare systems, that can do it. Fine, get sick. We'll take you on. We'll take you for a very long time. And you may have some disability. You may lose a leg from too much noradrenaline or some type of cardiac insufficiency, because that we've had a few of those. But time, I think. So I feel like, yes, it's very important to have like some type of drug or vaccine, but in the face of all the issues that right now that we don't have that time. So really social distance, stay away from other people, do what you have to do to just not get sick. But yeah, and I've got to go. So sorry. Very lovely to speak to everyone.
Thank you so much for being with us today, Melanie, and good luck with work. So we are now 2 minutes to the time, and I think a couple of our panelists can stay if people do have questions, but I also want to acknowledge that we told you would be with us for an hour, so if you have to go away, please feel free to do so. I think Tony and Anna, at least you can stay, right?
Yeah, I can stay for a bit.
I can stay for a couple more minutes, it looks like. I may need to leave, but for now I'll stay.
Okay, amazing. Cool. So I think
I need to leave, but I wanted to address Johan's question. What I've noticed as I've read about different countries' approaches, social distancing has a big impact on things, and also kind of societal discipline. When we look at the Northern European countries, they tend to talk a meter away from each other. When we look at the Southern European countries, they tend to talk inches away from each other. In addition to that, kind of the social discipline or governmental structures tend to be respected in the Northern European countries, maybe not so much in the Southern European countries. So I'd throw those 2 reasons out as to why it's working in Sweden, and it appears to be working, that they've opened up the economy, whereas it doesn't work everywhere. And in the US, you see a vast difference, again, if you're in Minnesota versus some other parts of the country where maybe the culture is different. Enough said.
Thanks for the comments. I think, Anna, do you have anything to say on behalf of the Southern European countries?
I don't think it's that much about Southern European countries because we have been on very strict lockdown here. And I really believe that the way to, it's not about responsibility or individual responsibility, but thinking about the community. And I really believe that even if the economic problems are going to be big, the lives matter more than the economy. And I really believe that the lockdown was the way to go. We were on a continuous spike up of cases, and with social distancing and with the lockdown, especially on the hard lockdown in which only very, very essential workers could go down. And I mean, like, I was asked several times on the street where I was going. I had a document saying that I was going to work on the hospital. I had to show my ID and everything. I think that those 2 weeks were key in Spain to contain the spread of the disease. I know that it's very hard, and we've been suffering from it. Like, I only went to work, came to my house, and did nothing. I lived alone, fortunately, so I did not have a problem such as Melanie said about living with people that are vulnerable to the disease. but I don't think that it's about southern or northern or about the responsibility of the self, but about the responsibility of the community. And the problem with not locking down is that you are asking people to do things that they may not think of the consequences of doing. So I believe that the lockdown was the way to go. It's not an easy choice. It was a very difficult thing to do, but I honestly believe, I wish we could have done something before in order to avoid the lockdown, but I think it was the way to go. And we're still in lockdown. Like, we are having a little bit more of liberty to move. But for example, in Madrid, we've been right now reopening things. And it's also very controversial to see how things are opening, because the schools are not open, but the bars are open. So it's interesting to see how it works and how the economy drives the world, instead of the health or the education system driving the world. And yeah, I don't think if that answered any of your questions. I hope it did. And also about testing, right now we are having a little bit more of a freedom with testing, but at the very beginning, some people we didn't have tests, so we couldn't test. For example, in healthcare, we're right now being given the serologies, but before, only if you had symptoms, you would get the test, not before. And right to go to the hospital, and for example, if you have to if surgery has to be performed on you, you need to go and be tested before you are admitted to the hospital, and that's all in preventing the spread of the disease in the hospital, as we are resuming the normal activities in the hospital. And with funding, I think that was Vera's question. There's never enough funding. That's the problem with healthcare. We need all we have, all we can get, and sadly we cannot get everything, because you have different resources and they have to go to different things. But yeah, specifically on funding on research, we don't, in Spain there's a very big problem with research funding, and it's usually private universities or private communities, private institutions that give the funding instead of the government. And I think that's another thing that we have to tackle in the next few years. So I think that's it.
Thank you, Ana. I think as a last question to close, if I may, I just wanted to ask you all, from your vantage point, what will the situation be in 6 months, in 2 years? If you could just speak to that briefly. And yeah.
Boy, I'm sorry, Tony.
Yeah, I was just going to say, everybody wants the status quo ante. That is human nature. But I don't think we're going to be able to get there for quite some time. The ability to do so is going to be completely contingent on the ability to actually control the pandemic, something which is still a hope and a dream, not a reality. Social distancing has done a tremendous amount, but there has obviously been a lot of economic suffering around the world. And whether or not one could continue to contain the pandemic by that means, I think is very difficult to imagine. If we're not going to be utterly dependent on social distancing, there has to be the availability of a successful vaccine and a successful mass immunization program. As Dr. DeFranco alluded to a few minutes ago, those are challenges that have yet to be overcome. There is tremendous amount of activity currently ongoing to develop new therapeutics and to develop vaccines by every known technology for vaccine development that exists. And I think we'll begin to see the fruits of those labors before too long, but we're still facing many unknowns, and probably another, I would say, 2 years at a best guess for a time frame to know if we're really going to be able to control this successfully or not.
Thank you. Would anyone have anything to add to that, or?
I can't improve on what he said.
Nope.
Okay, Johan, I know you have your hand raised. Do you have your hand raised? Okay.
Yeah, I was just wanting to tell Anna, because you talked
Mhm.
about how social distancing, how it's good with a lockdown. And I agree, because here in Sweden, it creates a kind of pressure. For example, I have school at home, but all my friends, because here we can basically do whatever we want to. So it's kind of like a social pressure to actually do things. But for example, my dad, he's sick, so I can't do a lot of things. So it creates a kind of pressure that the Swedish government only have recommendations and not like strict things that you have to do. So people can basically do whatever they want to, and that creates, I don't think it's good for the society, because then you can do things, but then at the same time you don't want to. But it's just that you can. That's kind of is the bad thing.
Yeah.
That is only recommendations.
Yeah, it puts the pressure back in the people instead of being like taking the hard decisions by the government. I think it's very difficult, and it hasn't been easy for anybody. But yeah, as you said, it puts a lot of pressure, because you can do things, but you don't have to. And it's difficult, and I really believe that it's been very, very difficult for all the governments to manage the situation, because it was unplanned. And as everything that is unplanned, it's always very, very complicated to see what's the right choice. And we probably won't have a right choice. It's just the way that we dealt with things. And the only thing that we need to know is that in order to go forward, we need to start investigating more, researching more, and funding the things that are important, in my humble opinion.
Thank you for that answer. Tony, were you gonna add something?
I just wanted to go back to Johan's question, because I think it's a very interesting one, and it has relevance for pretty much everybody around the world. The decision by the health ministry in Sweden was considered and intentional. It wasn't an accident. They looked at the data that they had and decided that they thought the best course would be simply to, as you said, recommend social distancing, but not to enforce it. And then, because the calculation was that the health system would not be overwhelmed by the volume of cases that they had, they assumed that they would be able to manage all the illnesses as they arose. So, if you have 1,000 people who become ill over a year, then maybe your healthcare system is fine. If you have 1,000 people who become ill in a week and your health system is overwhelmed, then you have not made the right choice. So it seems that we will know the answer to that question at some point in the future. But so far, to my knowledge, the health system in Sweden has not been overwhelmed in a way that it has been overwhelmed, for example, in New York, almost overwhelmed in Massachusetts, and in a few other states in the US, and obviously in some other countries around the world, where the impact of the pandemic was massive and swift, and just there was no ability of the healthcare system to accommodate those numbers of cases. So I think applying the labels right or wrong are very tricky in this situation. And my last point is that this is a situation where we are all dependent on one another. So together, we can all control this much better than any one of us can individually. So one person can take all the steps that they wish to try to prevent them from becoming infected, but those steps become so much more effective if everybody in the community follows them, that is the real key to success. And that's a challenge that we face here in the US, because there's tremendous divergence of opinion and feeling among the population as to the appropriateness of social distancing or the need for it. But that's we're all human.
Thank you so much. I just want to be, again, conscious of time. We are over time. Thank you so much, Anna and Tony and Richard and Melanie, that had to leave. It's always a bit bizarre with online events because there's no going up to the panelist at the end, because like when I close this, everyone goes. And so I will leave this open for a few more minutes after I say our goodbyes. I hope that this conversation has been interesting for all of you that have come, and that it has reminded you of like all the knowledge that we have as a community. And, you know, like if you haven't reached out to a CRS friend who's doing interesting things about whatever, like maybe this is a reminder to do so. And also a reminder that like we are not just a CRS community, but a global community that has to respond to, you know, like the pandemic or systemic racism or whatever it may be collectively. And also just a shameless plug, we announced 7 instructions in July. So if you haven't had a look yet, please do so, or reach out again. And thank you so much again. Like I know Ana just finished a 24-hour shift. She's going into a 24-hour shift tomorrow. I know, Tony, you're super busy as well. And so I don't know if you have any parting words, but thank you very much from us for being with us today.
Thank you as well. This has been very instructive. And I think it's very interesting to see how we dealt with this crisis in the different parts of the world. So I hope everyone's well, and I hope their families and the loved ones are well as well. And it continues to be so. So thank you very much for inviting me and having this conversation.
Yes, thank you. It was very enjoyable and I think very useful.